All right, so welcome everyone to our second day of the webinar series, Strengthening Nepal's Response to Fight the Pandemic. After yesterday's event where we discussed COVID-19, mental health and culture, and the huge traction that has generated in the Nepali media, I think we're positioned particularly well for these discussions and for talking about issues which are central to the pandemic. Not only, just to quickly recap, not only did our health experts talk about enabling prioritization of mental health during the pandemic, but some of them also spoke about responses across institutions in Nepal to deal with the challenge that the pandemic poses. There were many suggestions that came up, including implementation of knowledge, as Biraj had pointed out. And finally, with the way the WHO representative to Nepal summed it up, saying that Nepal really needs to focus more on getting the basics right. That's the emphasis for now. And you cannot overlook the mantra of test, treat, and trace. Of course, we had, other panelists as well talk about culture and how all of that, the social dynamic that the pandemic is related to and the intersectionality of that. And so very pertinent points, which brought about, what's the impact of mental health, the overall impact on mental health of the pandemic, and therefore more emphasis to be on these issues, mental health, health worker challenges, and gender-based violence. So actually, we couldn't be positioned better for today's discussion, which exactly focuses on COVID-19, consequences of COVID-19, including health worker challenges, gender-based violence, increased social inequalities. And so I would encourage all of you to participate as far as possible in the discussions and in the questions and so on. Moving on to the agenda for the day. So today we really have our first panel discussion on consequences of COVID-19. There will be a poll similar to the one that was yesterday, and followed by another panel discussion on governance and leadership. So our two main areas of discussion today are clearly listed before you. We will end the day hopefully on time today. We will try and be very strict about time and try and not overshoot our designated requirement from speakers. Some quick housekeeping for participants, which is really a recap from yesterday's. To keep your mic on mute and turn your video off. Please use the chat box to ask your questions, and you can also raise your hand using the icon. Do participate in the poll so we know more about your interests, and also we know how to better these sessions and these interactions. The slide deck that we're going to use for today's session will be shared with all the participants at the end of the session today. Feedback forms at the end of the webinar will also be brought to you, so that in addition to the comments that you make in the chat, we can also document some of your suggestions. Everyone attending the session today will receive a certificate of participation once all the steps are complete. And for those who are returning to us from yesterday, know exactly how this process works. For the people who are new, welcome. There are some housekeeping announcements for speakers as well. They need to keep their cameras turned on so that the audience can see them. Of course, you want to mute your microphone when you're not speaking. And I cannot emphasize enough, but please try and stick to the scheduled speaking timelines. Else we have tough moderators. Bernadette from yesterday is very much on this platform, and so I would encourage everyone to sort of just be mindful of time. With that, we begin our first panel for the day, which is consequences of COVID-19. And the moderator for this session is Professor Lars Lehn and Dr. Bernadette Kumar. I know we said Dr. Biraj, but he's busy in COVID response, and so therefore is unable to join the session today. Now that you see a picture of Lars on your screens, I cannot tell you enough about what a charming person he is, besides the fact that he's a specialist in public health and psychiatry, and all the accolades that you see on the screen. The other thing about Lars is that he has worked for more than 2 years with NURAD in Namibia. And therefore, he's very knowledgeable about the functions of NURPAT in terms of how Norway and Nepal collaborate on this global alliance for higher education. Besides being the leader of the National Norwegian Advisory Board on concurrent addiction and mental health problems, he's also professor at the University College Innlandet and University of Tromsø, where he supervises a vast number of PhD students, many of who are from Nepal. And so therefore, he's very familiar with the issues around mental health and public health in Nepal, more so now with the pandemic. All of you know Bernadette from yesterday. And I would request Lars to please introduce Bernadette to the larger audience. Lars and Bernadette have worked closely for a long time and are very proud of having that working equation. Lars, over to you.
Thank you very much, Ritu. Thank you for the kind introduction. I would very much like to introduce Bernadette Kumar. It might take the rest of the day because she has had a lot of influence on my work and a lot of influence on a lot of other people's work. First of all, Bernadette is a very nice and loving person. I really enjoy her friendship, but as a professional, she's very straightforward, working hard, and has done a lot to enhance especially cooperation between high and low income countries. She's been on a lot of boards, especially now on the Lancet Commission, and she has done a tremendous work to bridge the gap between knowledge that we need in developing countries. I think she has a lot of energy and is doing tremendous good work. And she's now placed in Nepal, and I hope that she will come back to Norway in not too long time to have more cooperation directly with her. But I think she's also done a very good job being placed in Nepal during these years. Yes.
Thank you, Lars. Thank you very much. I'm just trying to get back to I was trying to get a slide for Bernadette, but well, it's in my deck from yesterday. And so resuming with our discussion today. Over to you, Lars.
Yeah, thank you very much. I'm really looking forward now. We have 4 speakers for this panel. We do it like this. We have 10 minutes for each presentation, and then we have a discussion at the end. And as we did yesterday, I encourage you to use the chat, both that you can have direct questions and direct answers from the presenters. The first presenter is Lamu Sharpa. She's a medical doctor. She has an MSc in epidemiology and also a PhD from the University of Oslo, as far as I know. She's currently the senior advisor for the IPAS in Nepal. And as you can see from this list, she has a lot of publications and a very interesting relations with a lot of different institutes and collaboration around the globe. So we are very happy to have her with us, and we look forward to her speech about reproductive health and their challenges. So please take the floor, Lamu.
Thank you very much, Lars, and thank you, Ritu and Professor Bernadette and everyone who's here for giving me the opportunity to talk about the consequences of COVID and reproductive health and challenges for women in Nepal. So I'm Lamu Ingchin Sherpa. So can I have the next slide, please? So I'll start by talking about women's human rights and the country's obligations. The Constitution of Nepal has given certain rights to women. There are actually 32 fundamental rights and duties that links the citizens of this country to the Constitution, and which are the obligations of the state to its citizens. So Article 38 of the Constitution of Nepal and point number 2 clearly states that every woman will have the right to safe motherhood and reproductive health. And based on the article, the Right to Safe Motherhood and Reproductive Health Act came into existence in 2018. And the preamble states that the state must make necessary provisions on making motherhood and reproductive health service safe, qualitative, easily available, accessible, to respect and protect and fulfill the right of safe motherhood and reproductive health as conferred by the Constitution of Nepal. So what I'm trying to emphasize here is that women in this country have a birthright to access reproductive health and family planning services. We are not clients in this country. We are right holders of this country. So this is what I wanted to emphasize on this slide. The next one. So I'm not going to talk much about lockdown in Nepal because we've already heard a lot from the presentations yesterday. I just wanted to emphasize that the first COVID death was a 29-year-old postnatal woman from Sindhpalsok on 14th May. Next one, please. So challenges for women. There were a lot of challenges when there was a lockdown and during COVID-19 for women in Nepal. First of all, there was a lot of confusion among service providers whether to provide services or not to provide services because there were no protective materials. Actually, there are 3 to 5 family planning methods which are currently available in public health facilities of Nepal. And given the nationwide lockdown and spread of COVID-19 and unavailability of protective materials, for instance, like masks, sanitizers, apron, service providers have stopped providing services. At least 3 methods, implant, IUD, and injectables were not available for women in Nepal because of the proximity that they have or the procedure requires close contact with women. That's why the providers were not willing to provide these services. So in many areas of Nepal, the services were not available between several weeks to several months. And because of this, access to time-sensitive services like contraception and abortion care was interrupted, both due to lockdown and unavailability of transportation, as well as unavailability or reluctance of service providers to provide these services. There was also an interrupted supply of family planning and reproductive health commodities. Since family planning and RH commodities are in the essential list of services, they are usually procured from the federal level. So there was the supply was interrupted for several weeks to several months in some of the facilities. And since most of the many hospitals were converted to provide services for corona patients, there were limited service providers who were providing sexual and reproductive health services. And we have already seen from data coming from WHO and from different organizations that the maternal mortality during this period was much higher compared to the previous years. And because the services were not available or they were turned away by the hospital. And this also led to gender inequalities, which has been exacerbated by the pandemic. Gender inequality already existed in Nepal, a huge inequality, but this has been further exacerbated by the pandemic. The burden of unpaid care on women increased even more. Women who were having sexual relationship outside their marriage were expelled from the village, and they are still not allowed to return back to the village. Some of the women who were raped ended up becoming pregnant, have even given birth. One of them is at Maiti, Nepal, and many others became pregnant, and these are all unintended pregnancies. And a lot of adolescents who could not get services during the lockdown or family planning method attempted suicide. A lot of these adolescents and people have been rescued by IPAS staffs who were working in the field during that period. The final one is RMN's interim RMN-CH guideline was approved almost 2 months after lockdown. So approval took 2 months, and then it took several months to roll down this interim RMN-CH guideline. So reproductive maternal neonatal child health guideline is important because, like I've said earlier, for time-sensitive services like contraception and abortion care, if they are not availed timely, that could lead to unintended pregnancies and also attempted suicide if it's for unmarried women. Yeah. Next one. But we also found that there were a lot of opportunities. For instance, the RMN-CH guideline has approved the use of telemedicine for family planning and safe abortion services. And we have at IPAS have already started this telemedicine and family planning safe abortion services in 2 districts. We have been collecting data since September 2020. The RMN-CH guideline has also encouraged task shifting. It has also encouraged the availability of MA drugs, family planning methods through pharmacies. So these are all positive steps that we have learned, opportunities. And we have also learned that it is there are a lot of unnecessary cesarean sections that are happening in this country, and unnecessary hospitalization must be reduced. So these are some lessons for those who are going for cesarean section in the future, who are planning or who think that cesarean section is necessary. And there are people who are working in various sectors have also been working towards strengthening essential healthcare response to sexual and gender-based violence survivors, including mental health and shelter. And we have already heard through the panelists yesterday, and also a lot of people who are working on mental health, because this was a much needed agenda for this country. And because of a lot of suicide cases of suicide, this has received a lot of attention. So the survivors are receiving mental health care support. So this is also an opportunity. The other one is strengthening healthcare system to advance human rights. We have seen that women's human rights have been violated even during earthquake 2015 and also during COVID-19. So when I'm talking about health system, I'm not just talking about the 6 building blocks of the health system, because the 6 building blocks of the health system only talks about providers' perspective. We have to, when we are talking about strengthening women's human rights, we have to put women at the center. We have to understand why they are not able to receive services, what social norms exist in those communities, what are the forces that enable or disable women from taking those services. We have to build platform for them so that they can demand services for themselves. At present, what in most programs, what I've seen is that most of the budget, for example, 90% of the budget is spent on strengthening health system and 10% in the community. But we have to, now it's time to balance that proportion and to increase women's voices, women's choices, and women's human rights. So that's also an opportunity that I see. And finally, we have also understood how intersectionality, for instance, like distribution of risk factors, like disability, age, sex, gender, patriarchy, and distribution of power and resources create vulnerabilities. So through this platform, I would like to request all the future program policymakers to put women or vulnerable communities in the center when they are developing programs. So this is also an opportunity for learning through this COVID experience. I think that's all. Thank you.
Thank you very much, Lamo. This was very interesting. I think that we will come back with questions in the end. We have 15 minutes for that. And you can also follow the chat if there are some specific questions from your talk. It was very interesting. Thank you very much. Okay, we are having a small change. Actually, it was Subina Shrestha who was supposed to be the next speaker, but she would like to come as the last one. So we continue with Jasmine Ma. I'll be getting up her profile, Ritu.
Yes, Lars, just give me 10 seconds.
Yeah, no problem.
Alrighty.
There we are. There we are. There you can see Jasmine Ma. She is specialized in psychiatry from the CWIN University in Kathmandu. And she is providing mental health services for children and is associated with the Kanti Children's Hospital in Nepal. It's very nice. She's actually doing her PhD at the university in Tromsø, where I'm also a professor, and probably we'll meet there next time I will be in Tromsø. So please, Jasmine, we look forward to listen to your talk about child and adolescent health during the pandemic.
Thank you very much. Good afternoon, everyone. And I would like to thank everyone for giving me this opportunity to talk in this platform. So I think I have to begin because of the time limit.
Yes.
Yes. So I'll be talking about COVID-19 consequences in child and adolescent health. Can I have the next slide, please? Okay. So when we talk about child and adolescent before pandemic, let's say pre-pandemic era, there are normal daily activities of a child and adolescent includes just physical activity of, if we talk about the preschooler, it's 180 minutes of physical activity, of just 1 or 2 hours of screen time, and then a good sleep of 10 to 13 hours. And if we talk about the school-age children, they have 60 minutes of physical activity, 2 hours of screen time, and 9 to 11 hours of good sleep. So this was what a normal child and adolescent used to do. Next slide, please. And when we see a child's routine activity, they indulge into physical activity through travel to schools, games, sports. But however, the sedentary time and sleep are accumulated at home. So now after this pandemic and this lockdown, they're mostly confined at home. So most of the sedentary activities that they used to do at home is now accumulated more. And next slide, please. So when we talk about pandemic and this routine has been disrupted, this normal routine of going to school, sleeping, playing, meeting friends has been disrupted, and there has been school closure. There is restricted social contacts, and there's parental stress because of economic hardships and because of this COVID infection. Everything has burdened up. And When we talk about school closure, now that even all the children and schools have started this distance learning, but even though when we see the world data, 31% of school children worldwide cannot be reached by digital medium and remote learning. And when we talk about a country like Nepal, which is mostly like 17% are only situated in urban areas, and most of them are in the village where there is lack of technology, lack of digital medium. So their education has been hampered. And we see the Nepal data of COVID-19. It's 0 to 10 years of age has approximately 6,000 children have been affected, and 15,000 of children are, of 11 to 20 years has been affected with COVID-19. And though there has been lower risk of becoming severely ill and dying from COVID-19 where children are concerned, but reports have shown of life-threatening inflammatory disease in children. So we do not yet fully understand the long-term risk of COVID-19 infection. And there has been disruption in regular health services like immunization, well baby clinic, and nutrition. And children and adolescents could die from treatable and preventable conditions if immunizations are not met on time. And also because many families are unable to bring their children for care due to transportation disruption during lockdown and fear of contracting the disease if they go to a health facilities. So these disruptions could result in significant increases in preventable child mortality across the globe. And when we talk about children with special needs like autism spectrum disorders or intellectual disability, and when their normal routine has been disrupted, they cannot fully understand why this has been done, and they cannot follow the instructions. So what happens is they become frustrated and then short-tempered when their routines are disrupted, and their therapy sessions have been compromised, parent training sessions have been compromised, and children with special needs might miss the chance to develop essential skills. This has happened during this lockdown time, and also this is happening now. And when we talk about mental health, worldwide, approximately 10 to 20% of children and adolescents have mental health problems. And in 2016, an estimated 53,000 deaths were due to adolescent suicide, which is the third leading cause of mortality in this group. And in Nepal, during the press release, it has been stated that 40% increase in suicide rate among adolescent girls during the first 4 months of lockdown have been noticed, and it is, I think it's very bad, and it's a very bad situation. So next slide, please. And when we talk about the child protection issues, when we compare from 2019, this has certainly increased, and there has been abuse, child abuse, which has increased, child marriage has been increased, and online abuse has been increased. And the most devastating part is that we came to know during this helpline is that all the perpetrators were from the family members and during the lockdown period. So this is a very bad situation in terms of child protection in Nepal. Therefore, against this backdrop, children and adults in mental health problems is expected to endure long after the pandemic is over. And because of this, the child and adolescent psychiatry at Kanti Children's Hospital, we developed a manual which was COVID-19 related child and adolescent mental health stress management training. And this was stress management was for children and adolescents, even teachers, parents, caregivers, and frontline health workers. And this is an ongoing program that is, but we have a data till July to October where approximately 12,000 children and adolescents had been reached, and approximately 10,000 teachers, parents have been reached. And we hope that though this training manual is developed for stress management during COVID-19, but we hope that this stress management training will help in future crisis situation for teachers, parents, caregivers, as well as children and adolescents. And this, I don't know if we should call it blessing in disguise or the silver lining, but paradoxically, the pandemic has been a blessing for telepsychiatry, and telehealth have increased rapidly, and mental health professionals have become creative in order to continue serving their patients. And we hope that telepsychiatry will continue even when the pandemic is over. So we hope to give service to children and adolescents all over the country, because I think there are only limited number of child and adolescent psychiatry unit in the whole of Nepal, and people don't need to travel all the way from mountains or other tarai to meet a health professional. So this can be done through telepsychiatry even in the future. Thank you so much. I hope I was on time.
Thank you very much, Jasmine. You were completely on the time, and it was a very good introduction to the problems with domestic violence and how that actually affects children. It was quite disturbing numbers that you had to share with us. So we look forward to discussion after all the presentations. Thank you very much. Then we continue with CWIN Pant. If Ritu now is able to get him up, but I know, of course, CWIN quite well already. We have met. Here we have CWIN. CWIN is now a PhD student at the University of Oslo, but he's actually then working at CWIN University as a university lecturer. He's a psychiatrist and also very interested in addiction and the addiction field. So his PhD work will be on the use of opioid substitution therapy in Nepal. So we look forward to hear from you, CWIN, and your topic is mental health and increased challenges. So please.
Thank you, Professor Lars. It's good to see you. Good afternoon, everyone. So the topic that I'm talking about today is about the various health issues and challenges that key populations have faced during the COVID-19 pandemic. Next slide, please. Looking at the data from the National Mental Health Survey, which was recently done in 2020, we can say that about 10% of Nepali population has had any form of mental disorders over their lifetime, and which is about 5.2% in adolescents. What is worrisome is in the mental health survey, we came to find out that suicidality in the general population was about 7.2%, and the lifetime suicide attempt was about 1.1%. And this was a survey done across 7 federal states in Nepal, where we sampled around 15,000 population, 9,000 plus adults, 5,000 plus adolescents. So this actually was a good representation of the data and the mental health situation in Nepal. Can I have the next slide, please? But on reality, there is a huge treatment gap. So we're low in resources. All of you know that. We struggle with manpowers, building up with what Dr. Jasmine just said. Very few child and adolescent psychiatric clinics or services across the country, similar across general psychiatry and mental health services. But even while we have low resources, the equity for resources are even worse. So people from rural areas, apart from the major cities like Kathmandu and Pokhara, have very less access to mental health services, and due to which there is a big gap in terms of treatment and service. And stigma and discrimination, we're improving on that on a daily basis, but then mental health still is something that is a lot of, which comes with a lot of stigma and prejudice among people, and people think that mental illness is just related to psychosis and all these types of strong mental illnesses. And what the bigger reality is, we have a lack of intersectoral or interministerial collaboration. The main reason is because, mental health is a dimension across various disciplines. I can give you an example. The EDCD in Ministry of Health in Nepal takes care of mental health as such. ministry is taking care of the drug addiction problem. Then there's the elderly and geriatric ministry that is taking care of the elderly and geriatric population. Then there's the children ministry taking care of these things. So there is a lack of coordination and collaboration due to which mental health is diverse and scattered. One of the most important things that we lack is the mental health consumers. We don't have them in their involvement in policy framework or designing, so there's no adequate representation. We don't have meaningful engagement, and that is our reality. Next slide, please. Now, over the last 20 years, we are guided by the National Mental Health Policy, which was revised after 20 years, but it is yet to be ratified by the Parliament. Now we're looking forward to collaborating all the efforts into the National Mental Health Strategy and Action Plan, which is due to come in 2021, and we're looking forward to that. A lot of stakeholders have provided it. If you go by the mental health crisis in Nepal, I can tell you, being in a tertiary center in clinical practice, initially during the lockdown and the sudden corona epidemic starting, we had a lot of anticipated neurotic symptoms. A lot of them were anxious, depressed, and a lot of adjustment features. But now we're starting to see the neuropsychiatric sequelae of COVID-19. Just today, I saw a geriatric patient with some form of cognitive impairment as a sequelae of COVID-19 infection 2 months back. It's very common to hear that people are anxious, stressed, they've disturbed sleep. There's a whole lot of problem with smoking and drinking, all forms of substance use. Publications are starting to roll out. They're mixed findings. I'll share a couple of them in some time. But the biggest concern has been an alarming rate of suicide reporting that we saw in the early part of the lockdown. In the first 119 days of lockdown, there were around 2,200 suicide cases, which was around 18 to 20, which was quite alarming for our context. Next slide, please. What has been published, about 50 participants had at least one form of psychological problem. This was based on a survey done of the internet in Kathmandu. 1/4 woman reported increased workload during lockdown, and this is very evident. Yesterday also there was a lot of discussion on how women are overburdened during the pandemic. And there's this recent publication in BMC Psychiatry, which was a survey among 400 plus participants using the COVID-19 peri-trauma distress scale, which is quite interesting because about 90% of them experience no distress. And this was quite surprising. And there can be concerns or questions or research questions on resilience and these kinds of stuff that always strike with the Nepali community like us. So more research are due to follow. Next slide, please. Next slide, please. But on field, we can say that health workers have really suffered. There are a couple of good publications now. One on Asian Journal of Psychiatry, which is based on 4 centers, reported around 40% anxiety among healthcare providers and 8% depression. A recent publication in BMC Globalization and Health, there was around 40% anxiety, around 40% depressive symptoms, and a lot of insomnia among healthcare providers across Nepal. We recently did a study in the center where we're working, where we compared nurses working in COVID care unit and non-COVID unit. It has not been published, but then there is a lot of anxiety, and about 30 or 40% of them have shown anxiety caseness, and 15% has shown depressive disorders. And if you put around the borderline anxiety, the number will go high. And what was even interesting in this study was about 60 or 70% of these nurses were actually wanting to quit their job because of the stress that they had to bear because of the corona pandemic. Next slide, please. So what has happened in response? All of you are aware that the MHPSS has done a wonderful job led by EDCD and supported by WHO. There is a lot of advocacy around mental health. Never have we ever witnessed a time where mental health issues were so loud on radio and social media and everywhere. But again, the questions of equity and access, is it reaching everyone? Are people that are in actually need accessing it? And kind of questions come along. The crisis lines have finally been substantiated. They are dedicated lines now, and we have 3 or 5 dedicated crisis lines across Nepal now, mostly run by centers in Kathmandu. We hope that it will be decentralized over some time. We have 2 dedicated suicide helplines now, and we look forward for the other dedicated lines in the future. And also a lot of training work has happened, just like Dr. Jasmine recently said, a lot of training in child and adolescent psychiatry or mental health. And the healthcare workers have been trained by NGOs, INGOs, and now the government is developing a manual, and I think the training is rolled out on how health workers can manage their overall mental well-being and things like that. Next slide, please. So what can be the solution? Just like Dr. Jasmine said, such crisis can be an opportunity for a country like us. Mental health is seeking a lot of attention. And so the government had to take on ownership for all the efforts that has been made. We need a lot of interministerial collaboration because the domains of mental health are scattered here and there, and then a lot of intersectoral collaboration. And I think it's high time that we develop a separate strategy for suicide prevention because it is a major public health problem now. Next slide, please. We need a lot of manpower in organogram. I just want to mention, for a country with a population of 30 million, we have around 10 psychiatrists in the government organogram and no psychologists together and no occupational therapists. So I think we should sit down and just look towards developing the infrastructure required for providing the services. Community mental health services must be revamped, and research, which is actually being a lot done these days, must be done more in a community basis and should be more interventional type. Next slide, please. So in my conclusion, we came across a situation where there were a lot of mental health challenges. Nobody had answers. We were low in resources. So what has happened over the last 6 months of the crisis, 6 to 9 months of the crisis, a lot of us have come together. There's WHO, UNICEF, and all NGO, INGOs, academia working together, and some achievements have been made. What we should understand is even after the COVID-19 is over and we get to hear this vaccine news every day and we sense there is a light on the other side of the tunnel, the mental health crisis is here to stay. And not just crisis, there are speculations that it'll be a pandemic and it'll be a long pandemic that will have to suffer for years to come. So we should start acting now, not just for now, but also for the future. Thank you very much for your time.
Thank you very much, CWIN. This was very interesting, and you really showed the broad picture of really both the pandemic and the lockdown and the impact it has had on mental health. So it was very interesting. Okay, then we turn over to the last presenter this morning. In Norway, it's morning, and it's Subina Shrestha. She's a journalist and a filmmaker. We will have more about her in a few minutes, in a few seconds, hopefully. But I can see you're ready, Subina. That's very good. She's really an Emmy-nominated, award-winning journalist and filmmaker from undercover reporting in Myanmar, and also a lot of other places you have been actually working as a journalist. Very interesting CV that you have, Subina. We look forward to listen to your talk about gender-based violence. So please continue, Subina.
Good morning. I'm also in the UK and therefore it's still quite early. I'm going to start by, I've sent a link. If we could share that. I'm supposed to be an entertainer as a journalist. So this is, you guys are the first to do this. It's a short demo of a piece of work that I'm working on, and this has just been completed this morning. So
right. So I will start that now.
Thank you.
Okay, so far no changes. Let me try.
I've sent you a link as well.
Yeah, I think it's trying to load. Can you see the screen though?
I can't see anything.
Okay. Now?
I can see it, yeah.
Okay, good.
Yeah.
आदरणीय श्रोता नमस्कार, आप सबके हार्दिक स्वागत है रेडियो कार्यक्रम सवाल सरकार में। आज भी हमने कार्यक्रम में बलात्कार तथा बलात्कार जनित घटना के विषय में हमने चर्चा करते हैं। बलात्कार की घटना देखा जाए तो पिछले तथ्याङ्क अनुसार हरेक दिन 6 जनी महिला बलात्कार हो रहल अवस्था है। और चिंताजनक विषय का मधेसी और दलित महिला की संख्या देखा जाए तो सबसे ज्यादा। म सोना खटी, म सामुदायिक रेडियो कपिल वस्तुको स्टेशन म्यानेजर। जब रेडियोमा काम गर्न आएको थिएँ 2-4 दिन समाचार बोलिसकेपछि खटिक भएर मधेसी भएर दलित भएर अनि यसलाई थारू भाषाको समाचार पढ्न दिएको, को हो त्यो समाचार पढ्ने, किन दिएको, नाना थरीका क्वेसनहरू गरिराखेका हुनुहुन्थ्यो। मेरो बाबालाई नपढेकै कारणले र दलित पानी चल्दैन चिया चल्दैन भनेर सरकारी कामबाट निकालेका थिए। ए दलित हो मगन्तेको छोरी हो जति भनिराखेका छन् उनीहरूको चाहिँ मुख बन्द गराउनुपर्छ, तर त्यसरी भनेर हैन पढेर र केही गरेर देखाएर मुख बन्द गराउने हो भनेर त्यो चाहिँ आँट आउने गरेको थिए। राज्यले त दलित महिलाको यो समस्या होइन, उनीहरू त त्यस्तो समस्या भोग्ने जातै हुन्, सामान्य लडिराखेको छ। निर्मला पत्तको घटनामा त्यहाँ बोल्ने जुन महिलावादहरू छन् परामेरवाद भित्रै रहेर उनीहरूले सदनसम्म पुगेर पुरा देश थप्प भयो। तर यो रूपन्देहीकै अङ्गिरा पासी उनको पनि बलात्कार भयो र बलात्कारीसँग विवाह भयो। विवाहपछि उनी मृत अवस्थामा भेटिन्, तर उनको लागि चाहिँ आवाज अझैसम्म मौन छ। देश कहिल्यै थप्प भएन। नन दलित लोग तो बलात्कार करेंगे जब सरकार ही करवा रहा है। एक 13 वर्ष बेटी को शादी करके बलात्कारी के हाथ में देना तो सीधे सीधे बलात्कार वही बलात्कार करवा रहा है।
तो सामाजिक कानून पर एक मुल्की कानून बा, खास करके समाज में सामाजिक कानून यहाँ लागू हुआ दिखेगा।
So that is a very kind of early trailer of something that I'm working on. So the way I see it is, of the many things that COVID-19 has exposed is, and one of the more difficult things to acknowledge is how it's a reflection on the deeply entrenched values of our societies. And whether it is the systemic racial injustice in the United States to deeply entrenched gender inequalities, that especially intersects with caste, ethnicity, and religion in countries like ours. So between mid-March to the 25th of July, the months of lockdown, there were 4,448 cases of gender-based violence, according to Nepal police. And newspaper reports in the past month have shown that there were 89 cases of gender-based violence reported in the newspapers, and 73 of them were rape and sexual assault. 3 girls were murdered in this past month, and yet police data have more recently said that the rape cases in Nepal have gone from 5 to 6 last year to 7 a day now. And while doing this film, we've been trying to figure out the numbers of the reports and like trying to figure out the caste and communities of the girls who were raped and the caste and communities of the rapists. While these are not reported in the newspapers, it is also extremely difficult to figure out from police data. So we have been going to the police trying to figure out how, like if they have all the details and the data of the communities of women who have been raped. They have of the rapists, but we were told that for data protection reason, as well as reasons for community stability, these data are not going to be shared, and sometimes they do not even take it. But I mean, y'all are scientists, and you all know much better than me, but data is power. And I believe that should the actual data be revealed, then it would show the state's weakness to protect the most vulnerable. Like, for example, on the 26th of November, a 26-year-old man, Arun Kumar Shah, raped and killed a 6-year-old girl, Gul Afza, a Muslim girl. So according to the report by Third Alliance, a human rights organization, the police delayed the investigation even after the parents reported it. They reported the child missing. And what is most disturbing is Shah had been released in bail after he killed his own friend in early April. October 7th, the ward secretary in a district in Mathari, he attempted to rape a Dalit woman. Now, she has now been threatened to accept bribes, which started from 2 lakhs to now 10 lakhs. And because she's refusing to accept the bribes, she's been threatened with death. On the 23rd of September, an upper caste boy, Rajendra Bora, raped and killed a 12-year-old Samjana Bika. She got murdered in a temple, a Dalit girl. Bora had raped another girl, but local leaders had patched it up. In the investigation that you saw, where Sona was interviewing the mother of Angida Pasi, the man that you saw in the end, he was the guy, Amar Bahadur Chaudhary, who helped Angida marry the rapist, and she was found hanging. So what we found is most of the time when rape survivors become victims and they are killed, then we know the caste and the communities. And there was an article or an analysis by Sarita Parya in which it's entitled Ain't We Women? Multiple marginalizations of Dalit women in Nepal, in which it says, in Nepal, not all women are from the dominant caste, and not all Dalits are men. Nepal's feminist movements mostly centers on high caste, hilly Hindu elite women. It often neglects diversity amongst women. It not only ignores Dalit women, but also other marginalized women. In 2020, within 6 months, Samatha Foundation collected over 90 cases of Dalit violence, 31 deaths. Many of them have been Dalit girls who have lost their lives after being raped and sexually assaulted. I'm afraid what I'm leaving you with is more questions than answers on why there is no data and how, after so many years of development aid, why still we do not have all these data and why it is not disaggregated. That's it. Thank you.
Thank you very much, Sylvia. This was a very strong history, and of course this movie that you made also was very strong and emotional for, I think, for all of us. But it really sets the scene of what is actually the problem, and I believe that what you have come up with is also that the COVID-19 in some way exposed all these problems, and that we need to work on long term, because this is something that is underlying and that is just showing more of it due to the COVID-19. So thank you very much. Very, very nice. Okay, then we have come to the questions and answers. And I just want to ask my co-chair, Bernadette, have you had something interesting on the chat during these 4 presentations?
Yes, there have been a couple of questions in the chat. And the questions, some of them are being answered, but I think what we can do is, we can start with the question in the chat that is for Jasmine. Jasmine, the question that was for you in the chat is, some parents in developed countries have opted for disruption over online learning. Is this merely a choice they can afford given their relative ease? Or do they have legitimate concerns regarding cognitive, behavioral, or emotional impact of increased screen time?
Yes, thank you very much for the question. And I think I replied to Oliver, I guess it's name Oliver. But yes, I would like to say a few things to everyone regarding this Let me see the chat again. Yes. Yes, regarding the, where is the question? Yes, regarding some parents in developed countries over disruption over online learning, actually, maybe it's a reluctance to accept the online effectiveness of online learning and teaching, because this is a new normal, and maybe the parents are concerned over the effectiveness of online education, as well as yes, the concern regarding the increased screen time because of this online education. But I told him, like, maybe it's the reluctance to accept the effectiveness, because we do not know, because this is a new normal. And as well as, yes, there has been concern regarding increased screen time, which we do not recommend as a child in the child and adolescent clinic. We do not recommend more than 1 hour screen time for school children, but education must be continued. So so yeah, it's like both ways. But yes, something is better than nothing. Rather than disrupting the education, the children must get their education regarding, but we do not have the option to decrease the screen time for children. So education must continue, but hope this will not be for lifelong. And we have to, after this pandemic is over and this online education is over, we have to think about this decreasing the screen time as well, because of it might hamper the emotional attention problem for children. So yes, I hope that answers.
Thank you, Jasmine. That was good. I think that Lars, you had some questions for the other speakers.
Yes, thank you very much, Bernadette. As I mentioned, I think this was very interesting. But I would like to perhaps ask all of you to think about what we could have done differently, because I think all the four of you are actually talking about the vulnerable people, people with mental health problems, women from low castes, children experience domestic violence. Is there something that we could learn from the pandemic, from the lockdown, to protect these vulnerable people during the next pandemic? Is there something that we could do and learn from what you have seen with your experiences during this period? So it's actually to the four of you. So we could start with the first one, with Lamo.
Hi, Lamu, can you hear us?
Yeah, now I can.
Okay.
Sorry, I was unable to unmute earlier. So from this pandemic, what we have learned is that our focus, for instance, for reproductive health, family planning, or safe abortion services, or where it's concerned about rape, and even Subina ji has highlighted the issue about social norm, which is very important. What we have been doing until now in our programs is that we have put men and the religious leaders as our opponents in all our reproductive health, family planning, sexual violence programs. What we need to understand is that the social norm that exists for menstruation, the social norm that exists for family planning, the social norm that exists for reproductive health and for sexual violence, these opponents and the enabling forces are very different. So we cannot put them in one box and then say that all these are opponents, so we should build a program. This is a one-size-fits-all concept. And what this COVID-19 has exposed is that there are forces which support us when we go and think about changing social norms in certain societies. So all these factors, the enablers and the disablers, must be identified because they are different for different purposes and they should not be put in one basket. So that is my understanding. Thank you.
Thank you. Jasmine, do you have any comments?
And what we have learned from this COVID-19 situation in child and adolescent is like initially during the lockdown period, what the government has put everything on hold. Everything was on the lockdown, especially for immunization and clinics. And later on, they realized that this should not be done because we had put in stake of so many children's lives. And they started with immunization in every part of the country. So I think similar things should be in case of child and adolescent mental health as well. So we should not rely only on the center, that is the Kathmandu center. So every state, every hospital should have some kind of child and adolescent mental health services given, so that all the children will benefit where mental health is concerned in coming future, in pandemic or any crisis situation for future. I think so.
Thank you. Sagun, short.
Shagun, can you hear us?
Okay.
I think sometimes the mute, unmute takes a while.
Not able to unmute. Okay, should we ask Subina? Yeah, Sagun, please.
I think on part of what we have learned, me personally, I think policymakers must understand the urban and rural discrepancies and the needs. I think a lot of our policies reflect mental health from an urban perspective. But then the need of mental health services as doorstep is completely different for Kathmandu and Pokhara and major cities, and somewhere like Western Nepal, some rural village in Western Nepal. So I think the whole policy should look into the problem from let's say a broad overview of looking into different status of the society differently, understanding their problem differently, and bringing on different programs for them altogether. The other important thing, I think, what this pandemic made us realize in terms of mental health is we lack community mobilization in mental health. We lack, there's a great lack of consumer-based movements. People are still not openly coming forward, forming mental health networks like they've been doing for HIV/AIDS and maybe drug addiction now. I think it is a need of the hour that consumer groups should be formed, focusing on mental health so that there is adequate representation and meaningful engagement, so that that can be reflected on their policy reform, which will directly affect them. So that is my understanding.
Thank you very much, Sagun. Subina, do you have any short things to share? Subina, are you still on?
Yeah, that's the challenge with the virtual space.
Yeah. Okay. Perhaps it's she's left it for the day, but anyway, I think that she is also unable to unmute. Can you just wait one second to see if she's able to unmute?
Team, can you unmute Subina, please?
Okay, now I can. I've been trying to kind of just.
Subina, please.
I mean, with gender-based violence in particular, it is more of a structural issue, and whether or not COVID is there, it's going to happen. It has been there, and especially when it comes to the intersectional, especially the most marginalized, it's going to be worse. And I'm just going to give an anecdote. It's basically, there was a session that I had taken where a young Dalit girl in the middle of a session said that when she had a baby, she's a filmmaker, when she had a baby, she was slapped by the doctor. And so it kind of, it goes through every section of power, and even within the health sector, there's these kind of discriminations do exist, and violence is exerted on these most vulnerable. And unless there are more Dalit women represented or marginalized women represented everywhere, and in the media field, I mean, it is so bad that less than 1% of journalists in Nepal are Dalit women registered within the federation. So one can just imagine what kind of stories are covered and why they are covered and why it is not covered. So those issues are going to be extremely important in combating it. And it is not just a health or mental health issue or just violence issue. It is a structural issue.
Thank you very much. I think we should give a big applause to all the speakers today. And I think, Bernadette, that we conclude this session. And thank you very much. And also to Ritu for handling all the technical part. So thank you very much. And then I hand over to Professor Lavani to take us to the next panel. Thank you.
Thank you so much, Lars. I also have to thank Lars for excellent moderation, for keeping to the time for all the speakers, and it was an extremely powerful session. So if all of you are not squirming in your seat the way I am, then probably you missed some of the session. So it was absolutely thought-provoking. It has given us a lot of food for thought, and I also like that at the end we try to look at the way forward and solutions, because some of these problems that have existed from before have just been magnified with the COVID-19 pandemic. So now we'd like to involve the audience, the participants. So if Ritu, we can have the next poll. This is also, I'm sure none of you have fallen asleep because this was such a powerful session that you could not have fallen asleep. So if everybody could look at their screens and start voting. The poll has 6 questions. Please start voting immediately. What are your areas of interest? Public health, gender and diversity, mental health, governance and leadership, others. Are you currently involved in the COVID-19 response? Fully dedicated or majority of your responsibility? Indirectly or partly involved, not involved in any way? Do you have any training or education in public health, emergency or crisis management, or operations and logistics management, governance and leadership? None, some, quite a lot. What do you think have been the consequences of the COVID-19 pandemic on the mental health of the population? No effect, some effect, not certain. We have the votes coming in. Keep voting, people. Do you think gender issues and gender-based violence have received adequate attention during the COVID-19 pandemic? Yes, no, don't know. Do you see leadership as a priority in the COVID-19 response? Yes, no, maybe, don't know. So I see that 30% have voted. We will keep waiting as the votes come in. And to let you know that your feedback, your participation is extremely important. It's important for this webinar today. It's important for planning of future webinars. And I think some of these responses that you have will also feed into people's work in terms of COVID, in terms of mental health, and in terms of the other projects of collaboration that we have. So we've reached 60% of the votes. That's excellent. And we will keep the poll going for 2 minutes. So we still have a few seconds to go. Yes, now we have about 62% of the votes. I think maybe people have stopped voting. Okay. Up 65%. Come on, people, let's make it to 70. Okay, we're almost there. So as we can see from the poll, that mental health and public health, gender and diversity, as well as governance and leadership. So all 4 areas, but predominantly mental health. And of course, we did have mental health as a very big focus, was an area of interest. And I think what is also interesting is that we see that nearly 60% of those who voted are indirectly or partly involved. There is somebody who's having a problem with the poll. I think the poll has now, can somebody from the tech team please help Abdullah, because he would like to vote. And the next is about training and education and public health and all the areas. So there's some training, there are very few people with quite a lot, which means that we have a need to continue with these areas. What do you think have been the consequences? And everybody agrees that there's been some effect, 98%. So we're all in agreement about that. Some are not certain. And we also see that this is also almost 70% saying, do you think gender issues and gender-based violence have received adequate attention? Not adequate attention, and that is something that many of our speakers actually have also confirmed today. And do you see leadership as a priority in the COVID-19 response? And 80% have said that is the case. So with that, thank you very much for the poll, and thank you very much for active participation in the poll. So if we can stop share when it comes to the poll, it would be great. Okay. So please keep the chat going. I see that there's a lot of comments coming in as reactions to the first panel. And that has been very positive. Keep the reactions coming in. And once again, thank you to all the panelists and to the moderator. And now we move on to the last session, but not the least, of our panel discussion, of our panelists today, and of the webinar series. And the last session is on governance and leadership. And as we've seen, everybody does say that, does agree that governance and leadership is a very important area. And we also know that without governance and leadership, managing a crisis like COVID-19 is almost impossible. And therefore, we have an extremely competent and skilled line of speakers for you. And without much ado, we will start with the first speaker for the day. If I can have the slide. The first speaker for the day is Dr. Vinuta Silvanis. She has an MD in Preventive and Social Medicine. She's originally from India, from Mumbai, and at the moment she's Associate Professor and Head of the Department of Community Medicine at Nepal Medical College and Teaching Hospital in Kathmandu. And she has worked a lot with non-communicable diseases. She has worked a lot with community-based health. Her areas of interest are epidemiology, public health, nutrition. She's involved in research. She's involved in teaching. And actually, we were lucky to get her today at our panel. She's been correcting an exam and holding an exam this morning for the medical students. So, Vinuta, you are part of the health workforce. And as it has come through very clearly in our webinar, the health workforce has been at the forefront of this COVID-19 pandemic. So we now would like to request you to share your experiences with us of the health workforce, being part of it and also being part of the education system of the health workforce. Vinuta, the floor is yours.
Thank you, Bernadette. I can see my slides here. Thank you very much. I would like to thank the organizers for giving this opportunity to talk about the preliminary findings that we have from our assessment that we have done among the community health volunteers. Now, talking about my experience personally being a community person, medicine person in a private medical setting is quite a unique opportunity because we get to participate and sensitize our students as well as our staff to what are the public health requirements. Now, during the COVID pandemic, I'm happy to share that even early during the lockdown, we realized when everything was shut that we needed to continue with our immunization services. And so we have our community medicine OPD, where we offer under 5 children vaccinations. We offer family planning services for women, as well as DOT services for persons with tuberculosis. So we realized the importance of having to resume and maintain our routine services, and we were able to do that.
after discussion with our admin, and they were very supportive when we said that despite the lockdown and despite the cut down, we needed to reopen our OPD, and they gave us separate facilities to do that. And we're very thankful for them. And the community responded. You know, babies are still being born during the pandemic, and we have a lot of children coming in. And so we wanted to support them there, as well as women who desperately need family health services. So we're happy to be part of that. Our hospital also has beds which are reserved. But among the healthcare workers, there's been a lot of concern about having to work. And it's mostly the younger doctors, the residents, the interns, and the younger personnel who have been, actively engaged. We have tried to protect our elderly so that we can get appropriate advice from them, but keep them safe during this period. Now, going to so what led us to this study was that in a low-income country like Nepal, a sharp increase in the COVID burden can overwhelm the fragile health system. And it is important for us to understand at this time that the COVID response must build on existing platforms. We have understood that. We have to use existing infrastructure and relationships wherever possible. And therefore, we need to leverage existing platforms while reducing duplication so that we can have both short-term as well as sustainable impact. Can I have the next slide, please? This slide will tell us about the country capacity. So as of the 15th of April, 2020, this was what was the survey revealed as to how many beds, hospital beds we have, ICUs and ventilators. And as you can see, we are woefully short, okay? So can I have the next slide? So this, what we have understood is that we need to move from a hospital-centric approach to a community-level response. And therefore, our community health workers, whom I refer to as CHWs here, they are best suited to implement the community-level response at this crucial time because they already have a trust that they have established in the community, and this can be leveraged for them to carry out the work. Now, what can community health volunteers do? So globally, we have seen that community health workers have led to, in rapid testing, they can help with contact tracing, they can help with ensuring that people who are supposed to, isolate themselves at home continue to do that, as well as with quarantine. So all of this, we hope, will slow down the spread of COVID-19 in the community. However, we need to remember that the Indian experience during the early phase of the pandemic, where we mobilized a large part of our female community health volunteers, they had very, minimal protective equipment and shortage. And so we need to learn from that experience that we need to protect our health workers, especially when we send them into the community. Can I have the next slide, please? So in Nepal, the country response, so we have very good plans. We have very good thing in place, okay? So what our country response has envisaged that we should have a rapid response team, and which will carry out case investigations when we also have contact tracing teams. So these contact tracing teams include our community health workers here. And this has been thought that this is a strategy which is best placed to control the epidemic in the community. Now, in light of all of this, as we were looking at what was the response, the country response, we thought, let us find out, in theory, we have community health workers who are being seen as best placed to carry out interventions in the community, but what is the experience of our community health workers? So we carried out this pilot qualitative assessment to understand their experience during the COVID pandemic as well as their perceptions. So I had the help of my very able colleague from my department, who is a sociologist, and we developed a semi-structured interview guide. And we contacted the frontline health workers. We work with them regularly because we place our students in the community. We allot families. We have a longitudinal family study. So we work with them for community diagnosis as well. So we have good interaction with them. And so even at short notice, our sociologist was able to contact some frontline health workers. So in all, we had around 16 workers. And I can tell you from the response that all of them agreed to participate in our survey tells you about the rapport that our sociologist and our department has with the community. So we called them, we contacted them via telephone, and all of them agreed. So this is our baseline sample characteristics. All of our participants were female. Their age, was their age from late 20s to the mid 50s. A majority of them were female community health volunteers, while the rest were community motivators. As expected, they had a lower level of education, with the majority of them only having a primary level of education, and just 2 had gone on to college. They were mostly homemakers, playing a very important role running their families during. They also had small businesses, some were tailors, and one of them was a computer operator. Now, when we asked them their experience related to COVID, 1/2 of them reported that they had experienced symptoms which were suggestive of COVID. Okay, and out of 16, we had 10 persons who had actually gone for testing. So we can see that they had good access and they had been actually tested for COVID-19. The PCR testing was what was done most frequently, and they preferred to get tested in a public laboratory rather than a private, because of the cost consideration. Now, of those who had symptoms, 7 people preferred to use home remedies using hot water, turmeric, okay, all the local remedies, and it worked well for them, while only 2 went on to consult with a doctor. All of the persons preferred to be at home and isolate themselves there and did not need to be hospitalized. We asked them regarding their job and their security of those who were working. At least half of those who were working felt that they were likely to be made redundant because they were experiencing a slowdown in their business and as well as in their income. All of them expressed health concerns, but however, none of them reported any comorbidity. 8 persons also said that they were exposed to persons who were diagnosed with COVID at their workplace. Then we wanted to know about any training that they had received for COVID, and 1/2 of them reported that they had not received any training, while 4 said that they had some information, but most of this was gleaned from online resources. When we asked them whether they felt that they were well informed about the COVID-19 guidelines, which was relevant for their work as being part of a contact tracing team, 1/2 agreed somewhat that they had adequate information, while 6 were ambivalent. They were not very sure whether they were adequately informed or not. Can I have the next slide, please? Now, when we asked them, this was a free question, so we did not have any structure to this. We just asked them what was their overall experience, and they were very honest. And most of them said the most common response was fear, that they were fearful, they were uncertain, and they experienced a lot of confusion, especially when they had to go, when they knew that they had to go and look up a person who had been tested positive for COVID. They were worried for themselves as well as for their families. A lot of them also reported family conflicts, and they said this was a stressful situation, but that they needed to accept. A positive perception was that there was a learning, that they had to learn how to adapt, while a negative was that they had to face conflict and disharmony at home. What we thought that they would have trust, they found that during this time, people in the community were not very willing to engage with them because they knew that these were people who were having close proximity with persons who were already having COVID. So this just highlights, having all of them being female, with what our previous speakers have said about the mental health impact, about the stigma which is associated with health workers. As you can see, half of them had been exposed to COVID. So these are the challenges which our frontline health workers are experiencing, and these are my references. So I conclude my talk here. Thank you very much.
Thank you, Vinuta. Thank you very much for really bringing the health workers who are at the forefront of this pandemic response. into the picture. Our webinar would have been incomplete without that. And I encourage people to send questions in the chat to Vinuta and the other speakers, and we'll do a short, quick Q&A at the end of this particular panel. So we move on to the next speaker, and the next speaker is Deborah Healy. And Deborah Healy is the Senior Country Director for Nepal for NDI. And we've asked her, and she has spent many years in Asia. She has been in Thailand, and she's also been in Bangladesh. So she's no stranger to the region or to Asia. And she's going to focus on looking at how civil society can really strengthen responses when it comes to leadership and governance. So Deborah, thank you for accepting our invitation, and we look forward to hearing from you.
Thank you very much, Bernadette, and good afternoon, everybody. It's a pleasure to join you here today. While we deal with the areas of governance, health is a new area, I have to admit, for me. So please excuse me if you feel I have gone off topic in some way, but I'm going to give you sort of a broad overview of the work that NDI does, the role of civil society, and why civil society is important during crises, and especially during the pandemic. So as I say, for those of you who are unfamiliar with NDI, we are a non-profit, non-partisan, non-governmental organization based in Washington, DC, chaired by the former US Secretary of State, Madeleine Albright, that works to strengthen and expand democracy worldwide. NDI provides practical assistance to political and civic leaders, advancing democratic values, practices, and institutions. Since its founding in 1983, NDI and its local partners have worked to establish and strengthen political and civic organizations, safeguard elections, and promote citizen participation, openness, and accountability in government. NDI has worked in Nepal since 1994, conducting programs aimed at women's political empowerment, voter and civic education, anti-corruption, and parliament and political party development. And as the scope of NDI's assistance here in Nepal includes the strengthening of governance structures, we have continued to engage with our beneficiaries, not only to develop their capacity to address the COVID-19 pandemic, but also to support them as they continue with their wider roles through the institutions of government at the local, provincial, and federal level here, along with increasing their collaboration and engagement with civil society to address the needs of citizens during the pandemic. So what is civil society? It is not enough just to work only, on setting up democratic institutions and processes. These institutions and processes must be put to work, creating opportunities for citizens to lead healthy and productive lives. Ensuring that government actually works for the public good requires informed, organised, active, and peaceful citizen participation. Citizens must, therefore, understand ideas about citizenship, politics, and government. They need knowledge to make decisions about policy choices and the proper use of authority, along with the skills to voice their concerns, act collectively, and hold public officials accountable. The term citizen has an inherently political meaning that implies a certain type of relationship between the people and government. Citizens have a set of rights and responsibilities, including the right to participate in decisions that affect public welfare. In addition to the inherent democratic value, participation is an instrumental driver of democratic and socioeconomic change and a fundamental way to empower citizens. Civil society organisations are a vehicle through which citizens can aggregate their interests, voice their preference, and exercise the power necessary to effect sustained change. However, this requires CSOs learning to work together and to play a variety of complementary political roles that include acting as watchdogs, advocates, mobilisers, educators, researchers, intermediaries, and policy analysts. So then coming to the role that they play during a pandemic. And while the pandemic is ultimately a global health crisis, What it has also exposed is gaping holes in governance structures around the world. Nascent democracies, authoritarian regimes, and indeed established democracies all imposed some form of restrictions on their citizens to curb the spread of the virus. With vigorous checks and balances mechanisms, independent oversight agencies, robust civil society organisations, and a free press in place in established democracies, there was, by and large, transparency in the response of governments to the pandemic and the measures they imposed to curb the spread of the virus. However, in nascent democracies, semi-autocratic and autocratic regimes where oversight mechanisms are either weak or non-existent, the pandemic presented an opportunity to curb civil liberties and for corruption. According to the COVID-19 Civic Freedom Tracker of the European Centre for Not-for-Profit Law, and I would direct you to their website, since the onset of the pandemic earlier this year, 94 countries have imposed emergency decrees, 46 have measures that affect freedom of expression, 128 have measures that affect assembly of citizens, and 50 have introduced measures that affect privacy. And I think it is in countries where, you know, 2 or more of these restrictions have been imposed that the role of civil society in ensuring that the pandemic is not used as an excuse to curb civil liberties is an important one. And then coming to corruption, you know, another important role for civil society is tracking corruption during the pandemic. An inevitable consequence of the pandemic is the mobilization of taxpayer funds as governments respond to the public crisis within their borders and for donors providing much needed relief to emerging economies. The urgency of the measures needed to contain the contagion and mitigate its socio-economic impacts creates expanded opportunities for corruption. The risk is acute in countries where public finance management practices are opaque and healthcare systems are corrupt. Like community health workers, as Dr. Vunatha said, CSOs are typically more familiar with local circumstances than government agencies or emergency relief organisations, and they can therefore contribute to more effective solutions to problems caused by crises. Since many of the issues that a crisis creates requires collective action solutions, one of the areas where we at NDI have provided assistance to CSOs was by developing a guide that focuses on steps CSOs can quickly undertake in the aftermath of a crisis and emphasises the need for coordination between institutions, organisations and individuals. Focusing on our work here in Nepal, one of the organisations that we're working closely with here is Accountability Lab through their coronavirus CVAX campaign, which tracks the government's response and keeps citizens informed. Through a series of regular updates, the purpose of this campaign is to gather rumours, concerns and questions from communities across Nepal to eliminate information gaps between the government, media, NGOs and citizens. By providing the public with facts, the CCC ensures a better understanding of needs regarding the coronavirus and debunks rumours before they can do more harm. Some of the topics they've covered include school transport and employment updates to information on home isolation and community monitoring, for example. And we are also supporting them with a radio programme to bolster local governance. And the goal of this radio programme, which will begin this month, is to build trust, create opportunities to collaborate with citizens and local governments, and to raise awareness of accountability and transparency in the COVID-19 response. These are just some of the highlights of the role of civil society in the governance space. I could talk much longer, but time constraints prevent me from doing so. And in the fight against the pandemic, you know, having strong governance structures in place are as important as having strong healthcare structures and systems in place. And where there are failings, civil society can and must act as watchdogs and intermediaries between the government and citizens to ensure that governance structures not only remain intact, but are also strengthened for the benefit of the many and not for the few. So I will stop here. I'm going to hand back to Bernadette, and if there are questions later, I'd be happy to answer them. Thank you.
Thank you very much, Deborah, for that crash course in what civil society has done and can do. And I think it would be right to say there's no public health without good governance. So we really appreciate your sharing that with us. And I'm sure there'll be questions that will come up in the chat. If you could answer that, or we'll come back to the Q&A. And thank you once again for joining us. Our next speaker is Professor Paul Lalvani, who is the director, founder of Empower School of Health and the Empower Group. And as we mentioned yesterday, the Empower School of Health also has a Center of Leadership Development in Geneva. So leadership isn't, though it's supposed to be all inborn, intuitive, we know that it just doesn't happen on its own, and it requires both education, it requires training, and it also requires close follow-up. So Paul, without much ado, the floor is yours.
Thank you very much, Bernadette. Thank you, everybody else. If I could please share my screen. There we go. Thank you. And I know we have to stick to a rather tight timeline. So let me jump right in. Again, thank you, participants. I know it's been 2 long days. It's the second day. So the focus today, keeping with the theme of COVID, is about shaping leaders and leadership during times of crisis, which, as one can imagine, is tremendously challenging, especially in an environment that's ambiguous, complex, and really unknown. Very briefly about us, was we were already introduced, large-scale capacity building across developing countries is where our focus is, and we team up with northern and southern partnerships as well. Some of our partners, clients, and funders, we work very closely with academia, civil society as well, picking up on the last conversation, and support ministries of health. Within our areas of focus, leadership, coaching, and change management is a significant focus, and we'll share some thoughts about the current crisis. So what do leaders say about leadership? That's usually a good way of looking at things. And Jack Welch, a former CEO of one of the larger multinationals, referred to leadership as that before you're a leader, success is all about growing yourself. And as Bernadette rightly put it, we can learn, we can grow, we can pick up the necessary skills of being a good leader, understanding what is our own intuitive or inborn style of leadership, and then building on that. But then when you do become a leader, success is all about growing others. Maya Angelou, I've learned that people will forget what you said. They'll forget what you did, but people never forget how you make them feel. And that's extremely important as when we talk about leadership in action, and it's something we ought to remind ourselves every time. But how do leaders exhibit effective leadership during a crisis? And as unique as crises are, because they're often unplanned, they're black swan events, leaders must first understand not only their unique features, but also their common characteristics. And 3 things often appear in common anytime there is a crisis: that they demand a response, usually a very rapid response. They have unprecedented impact, and they tend to unfold in an unordered fashion. So the first half of the image shows in terms of what leaders normally do, responding in an established structure and environment with empirical evidence and best practices. But in an emergency, in a crisis, there is no blueprint. We need to rapidly aggregate knowledge and information to move forward. And then responding to these uncertainties of a crisis, this poses major challenges, and most urgent objective of any leader is to safeguard the future of their organization and its people. So if you're the Ministry of Health, and the challenge that we faced was that the frontline workers are putting themselves at risk on a daily basis. They are unprepared, uninformed, because there was so much that was unknown. But how can we protect ourselves and the people and the population to the best extent that we can? And step 1 in all this is accept that there is a social impact. Step 2 is to stabilize the organization the best we can, and that's what many organizations did. Yesterday, we heard from Dr. Pandav, the head of WHO, about how rapidly Nepal scaled up their testing centers, going from 1 PCR center to 77 in a very short period of time. So rapidly stabilize and grow the organization, face the uncertainty of the crisis, knowing that you will need to make decisions with incomplete information, and remain true to the DNA of the organization. And often in a crisis, what ends up happening is one lets go the fluff, the non-essential stuff, and focus really on the critical aspects that the organization must do to be successful in achieving its goals. But leadership without communication doesn't work. And some of the key aspects of communication and leadership, just to refresh, everyone knows these, but with connecting, to inspire, to listen, which normally one doesn't think of along with leaders, to provide critique and feedback, ensure there's trust, clarity, and definitely avoid monologue, something my kids often remind me. Prioritize, personalize, lead by example, and the last one, really important, openness, and share your vulnerability. People know, especially in a crisis like COVID, we don't have all the answers. Whether you're the head of a hospital, head of a primary healthcare center, or you are the Minister of Health, you need to be open. We need to admit that we don't have the answers. There is risk, and we are doing our best, and to actually do our best. But there are often, these are the common communication failures that leaders experience. And it's really important that, that we are aware of these if we are heading one of these organizations or a particular institution. Often there is a reason for us to hold back, and we're uncomfortable making decisions. But leadership does not, often leaders do not give tough messages when they are required. And messages are not delivered at the right time, which is critical, which needs to be at the right time. Give it too late, it doesn't have the right effect. Give it too early, it will have a negative impact. They need to be delivered with the right formats, through the right medium. What needs to be done in person cannot be done over the phone. What needs to be done over the phone should not be done with a text message, and so on. They need to be consistent. You can, of course, adapt as you have more knowledge and information, but the messaging needs to be consistent. Communications aren't delivered by the right people. If it has to be delivered by the CEO or the minister or the Secretary of Health, it should be delivered from the top. If it is just operational, if it is a tactical event or activity, it could be delivered by somebody more junior. But if it's strategic, if it is a change of direction, then absolutely it needs to involve the senior most leadership. So what have been some key leadership learnings from the COVID crisis? Number one, launch and sustain a crisis command center. And this can take different shapes and forms. Bring in the best that you have, bring in a multi-sectoral team of experts who can guide and support the different components, whether it's financing, whether it's health, whether it's laboratory, whether it's pharmaceuticals, nursing, etc. Bring in the experts who look at the crisis in a holistic way. Ensure operations continuity, which we know ground to a halt when we were staring at COVID in early part of this year. Strengthen the supply chain to support all health commodities. The focus shifted from first not knowing what to do to being fixated on PPE and COVID commodities. And as a result, many immunization programs suffered. Many other programs of HIV, TB, malaria, reproductive and maternal health suffered. Mental health suffered. So as we're focused on one, we cannot take our eye off the ball of the other ones. Stay engaged with health workers to protect, rebuild focus, and upgrade their capacity. Absolutely vital. And again, easy to say, how do we actually get this done? And we heard some of these examples in our previous speakers, And it's an area that we've been supporting more than 30 countries across Africa and Asia in designing, developing, and delivering public health content and materials, rapidly updated, teaming up with WHO, teaming up with the Global Fund, USAID, and various other entities to ensure that ministries of health and their health staff in the last mile are being able to respond, at least have the right knowledge and information to respond. Digital capabilities, because the physical just won't work in every case, although some of it has to be physical, but supplement with digital capabilities. And the last one is to build scalable ecosystems and expand partnerships. Within leadership and change management, some of the areas, some of what we've done these were, of course, physical workshops, as you can see, but many of them have now been supplemented with or transferred to digital learning. And the focus has been on change, not just leadership, but leadership with change management, crisis response, risk management. They're all built into our leadership trainings. The last example I want to show you with a couple of slides is one-time trainings never work. And what this project emphasizes, which is still ongoing, and this is across 10 countries in Africa and Asia, is referred to as a CEO Forum. And it's meant for senior level leaders in public health. This particular one is focused on supply chain, but it can be adapted to any public health cohort. And the idea is not a one-time training, but after you brought the target group together, and we're targeting here the existing leaders and the talent pipeline, the future leaders who we expect, or rather the leaders expect, will replace them and supporting them in the transition as well. So the idea is you build a community of leaders, a community of practice in whichever area. It could be done for COVID response, like we're doing with WHO CRO right now across 11 countries. It could be in TB, it could be in mental health. But the idea is you must create that community, sustain that community, and engage them over a period of time. And that's the idea here. You identify and engage them, strengthen them, and mobilize them. Physical and digital, relying more on digital today. These webinars that we're doing are a great way. And the way this works is not just through webinars, but the idea is you bring the learners together, you bring experts, both. I mean, right now, look at what we have. We have global experts, we have national experts. And so that's where this is the second box where it fits in. We bring in courses that the individuals can take, both the CEOs and the next in the pipeline, and the resources they ought to be reading to be updated and upgraded, all of which gets curated by the team, by us in this particular case. But what is critical is, unfortunately, after this webinar is over, we all dissipate. And this community of practice that we've created, the 80 people to 100 to 200 people that have come together over the past few days, will get dissipated. How do we capture them? How do we bring them together? And because there's tremendous value, they have come together for a particular reason. How do we continue to nurture them? So in this particular case, so there would be the mentors or the global experts who would agree to either volunteer or get paid to do this. And then the CEOs and colleagues or the learners in this case, who would also sign on. And these are the courses that we would curate and the resources. But built into that are the events and webinars, the discussion forums, and a direct ability for a learner, could be a CEO, it could be a junior person, directly able to communicate with one of the experts and mentors in terms of being able to stay connected. And when there's a next emergency or a next crisis, this community continues to grow and help each other with the South-South collaboration as well. So in ending with the last slide, while leadership skills are essential for any system, because change is constant, and a healthcare system, a health crisis, or just regular new policies, new products, new technologies are continuously entering the system. A leader and a really strong manager needs to have strong vision, the ability to have a coherent strategy, be creative, and most importantly, make the right decisions or make the best decisions given the knowledge that he or she may have. Thank you very much. Back to you, Bernadette.
Thank you so much, Paul, for taking us through the leadership process, in particular in a crisis, and also for all the offerings that are available when it comes to leadership and leadership management training. So now in this panel, we've heard from the frontline workers, we've heard about the frontline workers, we've heard about the work they've done and the challenges they face. We've heard about civil society, the role of civil society and how that can work in times of crisis, in times of pandemic, when it comes to governance. We've heard from Paul Lalwani what is required, the resources, the human resources, the leadership and the training. And last but not the least, we do need the finances, the donors, and we do need the wheels to be oiled in a way. And I'm very pleased that Cynthia Rowe, who's at the British Embassy in Nepal, who leads the governance and service delivery team for the British Embassy in Nepal, has joined us and agreed to speak to us at this particular forum and this webinar. And Cynthia has a long-standing experience in both leadership and as well as governance, in project planning, management. And I don't have time to go through her entire CV, but she has great experience both from Africa, Asia now, as well as the UK. And she's also worked with different country typologies, both fragile and conflict states to countries approaching middle income and those who have graduated from aid. So Cynthia, we're really looking forward to hearing from you. The floor is yours.
Thank you so much, Bernadette. And good afternoon, good morning, good evening to everybody, wherever you are. It's great to be here this afternoon. And thank you for a wonderful introduction as well. So I'm going to talk about leadership, but I am also going to talk about governance. And thank you for putting up my slides for me. I think we can skip through to the next slide already. Because I think that the two are different things, but they are really, really closely aligned. And also, the whole of the governance piece starts long before a crisis happens, and it can also change mid-crisis too, in my experience. So often the cracks and the strengths in the system are exacerbated by a crisis, and we can see that happening with the vulnerability of the poorest and most victimized in society in the UK, for example, with the Black and minority ethnic communities. We can see that in Nepal with women and girls and traditionally marginalized communities. And we've also seen how things can change mid-crisis. You only need to look at the politicization of COVID in the US, some of the backbencher discussions in the UK, and from my experience in Sierra Leone, how we positively change social behaviors during that crisis. So there is, it's super, super important. And I'm going to sort of draw on my experience of working on Ebola in Sierra Leone, which is where I designed the initial Ebola response framework and led the operational response. I was there for a 3-year posting, and in my sort of the end of my second year, it turned into a fight against Ebola at the time. And I'm extraordinarily proud of what we achieved. There was exceptional pressure with very little knowledge about what we were doing. And at the time, if you remember, evidence was telling us that there was about 90% plus mortality rate if you caught Ebola. So it was kind of a terrifying time as well. And I learned a huge amount from that. So very quickly, what did we do as the UK there? And this was working with a lot of other people, which I'll come on to in a moment. But in terms of what the UK did and what I was responsible for, terrifyingly, when I look at it now, £222 million that we spent over 8 months to set up what was essentially a national health infrastructure and the systems and the whole ecosystem that went around Ebola. And that included things like 11 fully equipped, staffed and managed Ebola hospitals, partnerships with about 20 governments and non-government NGO, non-government organizations. There was a ton of government agreements we constructed, we created a drugs and equipment supply chain. We trained 4,000 health workers in that time. It was a huge operation. And then I was asked to have a look at the post-Ebola transition. So I had a look, I set up the original recovery strategy, focusing mostly on rebuilding health, education and social protection, and then had some input into the policy concept for the UK Global Health Security Programme, which was called Tackling Deadly Diseases in Africa, because we wanted to learn from what had happened in Ebola. And when I look at the two pandemics side by side, Ebola felt like a sprint to bend the curve, as we called it, of infection before it got completely out of control. And that is compared to what I think of as a marathon that is COVID-19, which is this stretching out of a long, bumpy pandemic, which is going to take us at least a couple of years to get through, and then more time to get over. So why does leadership and governance matter? You know, governance covers a multitude of things. Institutions, rules of the game, accounting for what you do. As a governance practitioner, I'm expected to know, along with my colleagues, about a whole host of things. And sometimes we do know what we're talking about. Sometimes we're hazarding a guess. We never say which. Shouldn't joke about that. But it just covers this huge area. But some of my experiences in Ebola reinforced for me really, really starkly why leadership and governance matter, and they still matter today. So, for example, if you have a population that doesn't trust the health system or doesn't trust what they're being told by the state, they will act according to their own beliefs. And an extreme, but sadly not unique incident that is etched in my memory happened with one of the worst cases of spread that wiped out an entire village in Sierra Leone. And it happened because the people in the village didn't trust what they were being told by the state about washing hands and staying away from people who were sick and isolating. And the witch doctor said that if you, it's quite gruesome, if you cut up a body just after death and scatter the parts around the village, that is the way to cure Ebola. And heartbreakingly, that is what the people in that village did. And of course, we know that, that Ebola was at its most virulent in the few hours after death. And we saw quite a few of these incidents happening. And that was down to the fact that people didn't trust what they were being told or had no connection to the state. And they trusted the people who were in their local communities. And I know that one of the earlier speakers was talking about this as well. So, you know, the trust in the state is absolutely needed. The other thing that happened in Sierra Leone around the community response was there was years of underinvestment in education. So that meant that people, as I already said, had much more trust in local leaders. They didn't really use services. They were really wary of people who came into the community to deal with Ebola. And we had a lot of negotiations about consents to build units, to build whether it was isolation units, whether it was hospitals, whether it was smaller clinics. It turned out to be a real negotiation in some parts of the country. You know, all sorts of, there was a whole range of different issues that were all about governance. How do you get money to frontline workers when there's a system, when there's a really, really weak public financial management system? Who owned the budgets really mattered. How the money was getting to those people really mattered. So we ended up working with the World Bank and the private sector to get mobile payments out to people. I had a whole area of work which was around ethics and arbitration. So if you imagine, we had a whole bunch of very, very different people all being flung together to work on Ebola. And if you take two extremes in many ways, Médecins Sans Frontières, who is a very humanitarian-based organization whose approach to Ebola was to provide the largest amount of treatment that they could for the largest number of people in the simplest way, versus Emergency, which was an Italian NGO who strongly believed that every person in a developing country should get the same treatment as they would in a developed country. So they were proposing to set up kidney dialysis machines, for example, in the middle of the jungle, as it were. You can imagine the clashes that we had, and on top of that, of course, the Sierra Leone Medical Council was very clear that they needed to keep hold of what was going on in terms of the research and development that was going on during Ebola as well. So a whole host of things. Health workers went into shock, which resulted in paralysis, and there was infighting between parts of the international system, parts of the ministries, and all of those have real life consequences. So governance really matters. Next slide, please. So very quickly, I won't dwell too much on this, but in terms of what I did as a leader in that at that time, I was already in post. I was there as the governance team leader and the acting head of office when everything kind of kicked off. I will never forget it. I designed the framework of the response in a dark room with a small group of people over a stormy weekend when we realized what was happening. But then the really important stuff began to happen after that, which was about setting the scene with the government of Sierra Leone in line with the context. And it was things like agreeing that the president was going to lead the response and setting up a governance structure. And this is where the governance starts to come in. But I set out the parameters and the platform. We had a discussion back in the UK about should DFID lead this response or should the military lead the response? And we established that, that DFID was to do that, which meant I had to then brief in the military, more about that later. There was a whole bunch of stuff around changing social behavior and communicating properly with communities. So important. And some of that was absolutely heartbreaking, and it's so relevant to what's happening today. One of the things that we had to work with people on was changing their practice around burials and when family members died. So in Sierra Leone, the practice is to lovingly wash down the body of the relative who has died as part of the last rites. That, of course, is when Ebola is at its most virulent. And so we had to ask people to stop doing that. And it was a terrible, terrible, tough thing to do. But if we didn't do it, it was going to spread. I had to negotiate with a whole bunch of different players, and Paul was talking about this a moment ago, and try and get everybody to agree to play to their strengths. So the World Bank, Médecins Sans Frontières, the Norwegians, ourselves, the National Health Service, the Sierra Leonean Ministry of Health, and their military, along with our military, all had different strengths. Once you've negotiated that, it's really important to then trust people to deliver. And you have to let go and let them get on with it. And I employed what I called the searchlight method, which I learned from a fantastic director that I've worked with on this. And basically you scan the whole set of work streams that are going on. It's incredibly complicated. But then when you land on something that isn't working, you don't move on until a solution has been found. And you work around and within the different dynamics, you lever the politics. You have to be relentless in your search for a solution, and you have to ignore all the noise, and there is often a lot of it, unless it gets in the way of what you're trying to do. So those are the sorts of things that I had to arbitrate and that I learned from leading that response. So on governance, context is everything. And again, it is extraordinarily relevant to what's happening in Nepal and across the world as well. So, you've got to figure out what your context is. Do you have health workers? Do you have hospitals? Do you have citizens who listen to you? When I was briefing the military into Sierra Leone, I had to tell them they had to work with the systems, that they couldn't take over the system, even though that's often much simpler. How do you get incentives to people? For me, it was all about finding the right skills to deliver the response. And for example, I had an education advisor managing burials. And as I said earlier, we had the World Bank moving money around the country. And on top of that, we had to account for every pound of the UK taxpayers' money. No pressure. So just to sum that up, I learned very, very clearly that there is a connection between every single part of the system, between the health services, the government aid, the health workers, the supply chain, all of that. Even more so, there is a link to what the community leaders and the decision makers are doing and the accountability in those communities. And even more, as it gets more and more intense as you go down, there is a real onus to connect to what's happening to women, to girls, to the most excluded in our society, the most vulnerable, what's happening with livelihoods and what's happening with jobs. And I think you can skip to a couple of slides on. So the real question then is, what does this mean for Nepal? And this is a really interesting pandemic because what we call the secondary impacts here are as bad or almost as bad as the health effects. So I wouldn't, of course, I wouldn't say that they're as bad as the health effects in terms of lost lives. That is a non-negotiable, but the impact on livelihoods, on gender-based violence are so much worse for the people who are already vulnerable. And what we need to do as a group of leaders and as a group of people who are working on this is to follow and flex with the pandemic, trying to stay one step ahead of it and learning lessons really quickly and making decisions really quickly. We have that in common with Ebola, but the good thing in a weird way about COVID is that we have, and it's also a bad thing, we have much more global information and we have a lot of people working on solutions, which is helpful. There's a downside, which I'll mention in a second. The other thing is that COVID is happening in Nepal in the context of federalism. This is a country in political transition. And I will touch on that in just a second. And we have a global cluster system for coherence. So we need to rely on that and trust in them to deliver. And so what are we doing? My last couple of slides. So for the UK, we had a big reprioritization exercise as soon as we realized what was happening back in March and April. And we have reallocated our programme money. We are putting £43 million into the COVID response itself. That's in our eyes sort of humanitarian and health. We're putting £40 million to stimulate a post-COVID recovery. We have delayed about 29 million of our spend because it's not relevant or appropriate, or we can't do it because of the lockdown, for example. And we kept back a 3 million for other unexpected disasters. Hopefully they won't happen, but we were thinking about the monsoon specifically, but obviously the earthquake is always there. This isn't so much about the money, it's what you do with the money that really matters. And apart from using real-time evidence, which is incredibly critical, which we are also working on and putting money into, following the risks and the opportunities attached to federalism has become really, really important. So this is all about federal government in Nepal stepping up with the guidelines and with the strategic response, and letting the provincial and local governments determine how best to deliver that response to their local populations. And this is a really tough thing for this country to do. It has moved really fast on federalism already, but my goodness, this is a real test of it. You know, we look at the role of CDOs here. Is that a pragmatic response, or is that an attempt at re-centralisation? How are we using the planning and the public financial management systems at provincial and local levels? Can we account for the money that's going down? Is it reaching the citizens? We've had a lot of discussion about gender-based violence in women and girls in traditionally marginalised communities. I don't need to repeat what colleagues have said, but we know that they are suffering disproportionately, and we need to be making sure that we are creating agency for those people, that they participate in decision making and in accountability, and also that we continue to work on social norms. So there is a trade-off between saving lives and making sure that we do no harm and building back better. My final point, apart from making sure that we connect to other sectors, is that frontline workers are human beings as well as superheroes. I think that's really important to remember. And we have such distressing figures on mental health and resilience. We need to be thinking about how they are likely to respond. And I've got a ton of anecdotes, which I won't give you in the interest of time. So looking ahead, it is difficult to lift up your head when you're in the midst of a pandemic, but it has to be done. We know the vaccines are coming, so we need to, Nepal is in the process of applying for access to those vaccines. We need to prepare the supply chain, we need to prioritise, and we need to think about how we're going to administer that. We need to guard against infighting. It has real life consequences. I feel very strongly about this. It's really important that the entire system, whether it's government, multilaterals, bilaterals, we need to work together on this. And we are working on this against the backdrop of a global economic impact. So the UK has had a hit to its own gross national GNI, and we are temporarily dropping our ODA, our overseas development assistance, to 0.5 instead of 0.7. That creates a whole raft of work around the portfolio, about my own staff who are worried and concerned, about conversations with government and with suppliers. My approach to this is that we are in this together to find the best solutions for the wider good. And then finally, it's tough to think about this now, and it's a little bit, you know, this is like a month away from me, but part of this is all about how do we make sure we are building back better. The recovery from this will go on for years. We need to plan for at least another 2 years across the board in terms of recovery, in terms of the economy, in terms of what's happening to women and girls, and to really be aware that it doesn't just end when the pandemic ends. I hope I kept vaguely to time, but thank you very much for that.
Thank you so much, Cynthia. It was so important to have your perspectives. I think what you really through is that even the pandemic has disrupted global interdependence. We have to keep up with the global interconnectedness, both at the global level, but also at the country level. And I think that, again, the pandemic has taught us that we can't have silos. Health is not a silo. We have to work together intersectorally. So thank you very much for those perspectives. And yes, we are a little bit over time, but as the chair, I have the privilege, I hope, to ask all our speakers one question. So the 4 panelists, I'm going to ask you only one question. As you know, today is the 4th of December, which means we are 20 days away from Christmas. And if Santa Claus were to ask you, what would you like for Christmas? And in this context, we're talking about the pandemic, we're talking about referring to what you talked about, what would you ask for? So Vinuta, would you like to go first, then Deborah, and Paul, and then Cynthia? Very quickly, please. This is your turn.
All right, so for the hospital I'd like to ask for more PPE, adequate PPE, so that we can protect our people better. And I'd like to ask for support for our healthcare workers. I'd like to see how I can, you know, I would like something, a vaccine for the fear, a vaccine for fear rather than vaccine for COVID.
Thank you. Deborah?
Thanks, Bernadette. I think to echo what Dr. Vinuta says, yeah, the vaccine, obviously. I'm looking forward to its arrival globally, but also transparency in the rollout of the vaccine, especially in least developed countries. I think it's very important. I mean, Cynthia touched on that, on the need for everybody to work together on this, and I think that that's very, very important, and especially in a place like Nepal, in a least developed country.
Thank you, Deborah. Paul? Okay, since maybe Paul is having problems, Cynthia, you can go.
Thank you. I'm going to ask Santa for 2 things. The first is that we really pull together with our eyes. We keep our eyes on the prize, because we can beat this if we do that. And the second is a huge focus on the most vulnerable people in all of our societies. Let's prioritize them and pull together to make sure that life is not disproportionately worse for them. Thank you, Santa.
Thank you. I wish I was Santa. This is one occasion that one would like to be Santa and grant everybody's Christmas gifts. But I think what this has shown us in this particular panel is that there's a lot that we still need to do. We have miles to go before we sleep. And if we do it together, it will be much easier for everybody, particularly for those who need it most. Is Paul back with us? If he's not, I'm going to then ask Dr. Saroj very quickly to summarize, and then we'll try to say thank you to everybody. Professor Saroj.
Yes, thank you very much, Professor Bernadette. I think thank you very much all the speakers, panelists, chairpersons, and our participants. We are going to complete our 2 days webinar series on strengthening Nepal response to fight the pandemic, which was, I think, fruitful. I think we need to change the fear factor into the faith, people's faith, regarding how to prevent from the, how to prevent or how to take care of yourself from the COVID-19. So this was actually a great opportunity to share our ideas and our practices during the pandemics. And it gave us a greater understanding how we responded to fight the COVID-19. So on behalf of our host, on behalf of our department, on behalf of all of us, I would like to thank Professor Paul, Dean Director, Empower School of Health, Professor Bernadette and Ritu, because of your significant contributions. I think it's a great that I have learned so many things from your sides. So thank you very much, Bernadette and Ritu. And all the speakers, Professor Lawrence and Professor Jaswan from McGill, Dr. Norpat Coordinator, Dr. Suresh Thapa from Oslo University, and of course our keys notes speaker, Dr. Rajesh Sambaji Rao, new WHO representative to Nepal, and all our panelists and our speakers, and of course all the distinguished participants from Nepal and abroad. Thank you all for making a success of these 2 days webinar. I'm sure that these 2 days discussions upgraded our knowledge and attitudes that will help the lives of all those who have been affected by COVID-19 pandemic and their mental health problems. So I just want to share one quotation, Bernadette, because during the lockdown periods, I found that I felt alone, loneliness for many days. So today what I found, I want to share one quotation. If you are alone, your value is less, you have less value. But if you are along with the intellectual company, you are invaluable. So today's discussion and yesterday's discussion, I found that so many experts, so many intellectual companies among us, we are together, and if we work together, then I feel that I am also invaluable. That's my experience, especially during lockdown time. Finally, thank you very much. I wish you all good health, all the best, and hope to adapt the new normal situations in the coming days. With this, I would like to conclude. Bernadette, thank you very much. Over to you. The final words.
Thank you so much, Professor Saroj. Thank you to all the organizers. Thank you for the Empower team behind the logistics. You know who you are. Ritu for holding everything together, to all the speakers. And as you leave today with the thought that together we can really fight this pandemic and strengthen Nepal's response. You will be getting your certificates, the presentations will be available. And as Paul Lalwani said, let's try to see how we can keep this community together and not be alone, as Professor Saroj said. Excellent way to end it. So goodbye, and wish all of you the best. And hopefully we'll see each other in 2021 with the advent of a new vaccine and something to look forward.
Okay, thank you very much.
Good afternoon and goodbye.